coworker. Thank you. I have two of my colleagues here who are going to assist in this presentation, so I'll let them introduce themselves as well.
Hi, I'm Rachel Martinez, and I'm the clinical instructor for the Portland State Lactation Program.
Hi, I'm Dixie Wetzel, and I am an adjunct faculty, and I'm also the primary advisor for the program.
And we'd love it if you're available to introduce yourself to the group or just in the chat, just a little bit about where you are in your IBCLC journey, and then maybe also where you are in space, in geography.
Hi, I'm Jamie Schmid, and I live out in the Columbia River Gorge and on the Washington side. And I am planning to start the classes at PSU this fall.
Welcome.
Thank you.
I'll go. I'm Sharissa. I'm a PSU lactation program alumni, baby IBCLC. I'm in the Gresham, Portland area. I'm a birth doula and still finding my way in the lactation space. But I am here to learn more about the clinic setting. Am I missing something?
Thanks, Sharissa. Nice to have you. Is anyone else available to? Yeah, there we are. Sydney, hi.
Hi, my name is Sydney. I work for WIC as a new work at a class breastfeeding programs manager. So I'm going to be completing my prereq and doing all my IBCLC stuff in this next year. I'm so excited. I've been a breastfeeding counselor for 5 years at WIC. I joined this meeting to see Mary Watchsmith. She was my old supervisor. And I also work with Kira as a health educator at Legacy. So just excited to see what these ladies are up to. And thanks for having me.
Thanks for coming, Sydney.
Nice to see you, Michelle. Hi, Dixie.
Are any of the other participants able to say hello?
Hi, I'm Jules.
Hi.
Hi. Hi. I'm a certified lactation specialist and an LPN, and I'm currently working in an OB setting as like the triage nurse, and get to triage most of the lactation questions and concerns that come in. I was previously a breastfeeding coordinator for WIC in a rural community. And so I'm just here to learn a little bit more.
Great.
Yeah, have some community. Yeah, thanks so much.
And Jules, what part of the country are you in?
Oh, I'm in Portland, Oregon.
Oh, okay.
Yeah, thanks so much for having this and having me.
Sure. And then I don't know if y'all are seeing this, but we have a Gina from Texas who's working as an outpatient consultant, and Allison in Virginia. So thanks to all of you for joining us. And I think I'm going to turn it over to Rachel, who will introduce our speaker and take off from there.
Hi, well, I'd like to welcome everyone here this afternoon. So great to see some familiar faces and some new faces. I'd like to introduce Nina Horn. She is a graduate of the Portland State program, and she has kind of very serendipitous story to share of how she not only landed in a clinical, an outpatient clinical space, but how she actually had to kind of create it from the ground up. So without further ado, I'd like to introduce Nina. As you have questions for Nina, you're welcome to put them in the chat. Or if you don't hesitate to ask questions if you have questions of anything that Nina might be talking about today. Welcome, Nina.
Hi, yeah, thank you, Rachel. And I'll say I was prepared for more of a Q&A, so I don't have any particular speech or story prepared to share, so feel free to ask questions. And I've had a
Nina,
bit
how
of a
about we do
busy,
this?
yeah.
Sorry for interrupting you. How about you just start with when you finally received your exam results and kind of what your job searching was like and how you then landed in the clinic.
Yeah, okay. So I received my results, so it would have been December of 2022. So about a year and a half ago, and I started the job search right away. And as you all know, it can be really slow going. You're just like watching for those positions to open up. And I had applied for an inpatient position at Adventist Health, and connected with the director there, and yeah, just had a great conversation, but didn't get that position. And then I saw a couple months later, I saw an outpatient position open up there, which I was very excited about, and reached out to them, and they had kind of already had my name, and we'd had a good conversation when I had applied before. And so they had kind of already passed my name along to the hiring manager, which was nice to hear. And in the meantime, I reached out to a lot of other people who had experience here, worked here before, because I wanted to find out more about it. And turns out one of the midwives that my midwife knew and who I had known from way back when my first kiddo was born worked here. They had just brought on several midwives to the women's clinic here. And so I was able to talk to her and get like a really good kind of inside perspective on what they're doing here. And as it turns out, she's also was a huge part of bringing on lactation to the women's clinic. And so it just really worked out great to connect with her before. And I had an interview and got the position. And yesterday actually was my 1 year anniversary. So it's been really wonderful to be here. But yeah, you can ask me more about starting it up because there was a lot to do.
Yeah, and so maybe what we can share with everyone is that there was no lactation services there before you came, correct? Yeah. So
yeah,
as
they had an in yeah.
So as a new IBCLC,
yeah, just an inpatient in the hospital. Yeah.
Mm-hmm.
Yes. So in the women's clinic, we have 9 CNMs, 9 midwives, and 4 OBs. It was a little smaller when I started, but one of their conditions when the 8 midwives came on was that they also wanted lactation at the clinic also. So they hadn't had it before, and had been kind of doing some outpatient in the hospital, on the birthing floor. They would see, patients that really needed to come back. So they would be doing those as outpatient, but in the clinic we didn't have any. So they didn't. There wasn't a lot of anything built in place already. So I was brought on to start it up as well. Yeah. And within about a month, I was seeing patients, which I look back and that seems it felt like a long time at the time, but looking back, it seems pretty incredible that, I had an empty room to start with, and was seeing people about a month later.
And so maybe you can speak a little to now, you're not in a pediatric clinic, you're in a midwifery clinic, but maybe you can talk a little bit about how the services you provide both support the practice and support the families that, participate in the midwifery practice. How has it benefited the families there that you're actually in the clinic?
I love that aspect of it because I work closely with the midwives, so they will refer patients to me for prenatal visits. And we've been doing a lot more of those, which is, I just love doing those. It's fantastic. And then I'm also able to see them again after they give birth. So it's really nice to have that follow through with them. And then also our clinic patients are seeing our midwives at 1 week and 3 weeks, and then again at 8 weeks. But especially at that 1 week check in with the midwives are able to identify, how breastfeeding is going, and then refer them to me. I can also do warm handoffs with them. So their 1 week is usually a virtual, so they're not in. But at that 3 week appointment or at a prenatal appointment, if they're having some more immediate need or have questions, if I don't have a patient, I can pop in and see them while they're in their appointments. And then it works out really well too, just when there's prescription needed, or I can grab a midwife to come in and look at something that needs their care as well. So I really, really love being in a place where I have that partnership. Same with the OBs. Yeah.
I also think it's worth mentioning too, it looks like we have a mix of both non-RNs and RNs here in our group today. And you're not an RN.
No.
Correct. Yeah. And so I just, wanted to bring that up because I know sometimes there's a lot of questions about, will pediatric clinics or will, like in the case of Nina's, will midwifery clinics who have these lactation services hire non-RNs? And the answer is yes. We're going to have some folks coming on a little bit later that actually do work in pediatric clinics, and they can speak to that as well. Yeah. Good. All right. So far, anybody have any questions for Nina about any particulars? Michelle looks like she has a question.
Yeah. Do you know, Nina, did they have to jump through a lot of hoops in order to get reimbursement for your services?
So that's a great question. And I figured that out, Michelle. One of their questions in the interview is, do you know how to get paid? Do we know how to get paid for? And I said, no, but I'll look into it, And so that was kind of this first few weeks, like looking into how do we get paid for this, as it's different in every city. We're considered a hospital-based outpatient clinic, and so the way we get reimbursed is going to be different from an outpatient clinic in the hospital or pediatric clinic. So we do incident to billing. So I bill under the midwives. And there are a lot of little hoops though that we have to always be jumping through to be able to do that. The patient has to be an established patient of the clinic, so that's fine for our clinic patients, but I also see anybody who delivers at the hospital, and so they have to kind of establish care here with our midwives first, which we can do in my visit, but that means the midwife has to come to part of the visit, and so there's just a lot of it when you get into the documentation and how it's scheduled and charted. It's a little bit confusing, but that's how we do it. It's called incident to billing.
And it's TO, not the number.
Yeah,
right?
yeah, incident. Yep, incident to the midwife. Yeah, it's kind of, they have to have a plan of care in place, and then it's essentially, me carrying on their plan, which of course is not, how it doesn't actually work that way, but that's what the insurance companies want to see. So.
Right.
And now, do you find that you generally have a full schedule? Like, so what does your schedule look like? What are your
Yeah, so
working
that's a
hours
good
look like?
question. I not yet. I am here 32 hours a week, so Monday through Thursday, full days. And I have right now, I just have 4 appointment slots a day. So they're a nice long 90-minute slots with, some time afterwards for charting. That was something I set up from the beginning. And since I'm not all the way full, I've been able to keep it that way, which is great. So I'm not always full. Like I always have a couple of appointments during the week. Some weeks are even slower, where I might just have 2 a day or so. Yeah. And then there's a day like today where I had one in the afternoon and then I crammed 2 more in. So because people are calling. So, but in general, no, I'm not all the way full yet.
All right, looks like Gina has another question about billing. Is this type of billing done for private health insurance and state government health insurance? So all
Yeah.
insurances?
Yeah. Yep. Yeah. We take all insurances. And that's one of the things that I really love about being in the clinic setting is just our accessibility for so many patients. I think 80% of our clinic patients are on state health insurance. And so this feels really good to be able to provide lactation care to folks who, wouldn't be able to normally afford someone coming to their house. But yeah, the only insurance we don't take is Kaiser and Providence.
Well, it looks like
And I'm not sure, I'll just say incident to billing. I'm not sure, you'd have to look at your own state requirements for that. It might be a little bit different in different states, as far as what, but it is specifically set up by government healthcare. Those are what the guidelines are. So state insurance falls under it.
And Julie, it looks like you have a question.
Yeah, thanks. And you answered some of my questions with it sounds like the midwives set up a care plan and then you follow it and whatnot, which is kind of what I do at my clinic. But I'm wondering about, do you see every patient for like a prenatal lactation contact, or how do you go about that?
No, just I don't see every patient, only patients that request for a prenatal or I just see them pop up on my schedule. So
Okay.
I think they're from when they're having a prenatal appointment with a midwife, and they're really great about asking them if they want to have a prenatal lactation appointment with me. And so then, I'll see them usually in the 3rd trimester sometime. But for prenatals, I'm only seeing our clinic patients. Yeah.
Okay.
And as far as the plan, care plan from the midwife goes, it's very vague. It's like patient will see, IBCLC for lactation care, like that.
Right. Okay.
I'm the one telling them the plan, and then they have to sign off and say like, I agree with the plan of care. But
okay.
Yeah, as long as it's written down, that they
Yes.
say they'll be seeing me, then that's good enough.
Yeah, I understand that. And then it sounds like, just to make sure I understood, because where I'm at, I'm kind of trying to build something from scratch also in a very busy OB-GYN setting. And it sounds like then you are billing under the midwife, which is kind of like, for my contacts, is kind of how I've been doing things now. If it's needed, unless it's very simple. Is that right?
Yeah.
Is that what I heard you? Okay.
Yep. All my appointments are billed under them. Yep.
Okay. Thank you so much.
Yeah, of course.
So when you're talking about those popping in and speaking to people prenatally, Gina's question is, do you bill for that?
Yeah, those, if it's most of my prenatal, conversations are in an actual appointment made with me. Yeah. And that is that is billed. Occasionally I'll come in, if somebody's having a particular problem and I have time, I can do what we call a warm handoff, where I'm just coming in for 10 minutes after their midwife appointment. Those aren't billed for. We could probably, but I don't need more hoops to jump through and paperwork. So I'll just write a little note. I'll add a note onto the midwife's visit, that I came in and this is what we talked about.
And just while I'm thinking of it, because we always like the opportunities for networking, would you be okay putting some contact info in the chat so that if others have questions after today, they'd be able to get a hold of you?
Yeah, for sure. Yeah.
Great, thank you.
I'm on my phone right now, and so I'll do it right before I leave.
Okay, yeah. It looks like Sharissa has a question.
Yeah, just a question. I have felt very nervous about working with older babies because in all my experience, it's been kind of like 6 weeks or less. Did you feel nervous being put into an outpatient setting where you were going to have a wide range of what you were going to see, or did you kind of just go with it, or did you feel confident in it? Can you speak on that?
Yeah, no, I still feel nervous about seeing 1-day-old babies and older babies, sure as that. Because most of the babies I see are about, 4 days old to 6 weeks old, or, maybe eight weeks old, maybe 3 months old. And the vast majority are around like 1 or 2 weeks old. So that's, I feel really dialed in and comfortable with that age, but, occasionally I'll go over and help out inpatient and I feel like a fish out of water over there. I'm like, what is a 1-day-old baby, doing? And, so it's funny how, you do get kind of this comfortable in your zone and then, I mean, like I do feel a little bit just out of touch with those age groups that I don't see as much anymore. I don't tend to get a lot of older babies here. I'm sorry, somebody else will have to read that chat. So I'm so little with you, Sharissa. I don't see a whole lot of the older ones. So yeah. I have one coming in this afternoon and I'm kind of like, oh, I wonder what they want to talk about,
Well, I guess I'll definitely ask this question if they're not already here to whoever's at the pediatric clinics because I'm really I applied for that job that was here in Portland and I didn't get it, but I was really nervous just applying because I was like, if someone handed me a 6-month-old baby and said, here's a problem, I was gonna be like, I love this baby, but I have no idea any issues with this age group. But I guess that I can ask that question for the next person too. But thanks for the insight. I love when people keep telling me that they're still nervous.
Yeah. I mean, I think until you do things over and over and, each time you have a new thing, I think we all just have to be learning all the time. So, I'm with you.
So speaking of Pete's clinic, our other two speakers were also got, kind of surprises on their schedule today. So hopefully they'll be able to join us soon. But I was wondering, Nina, did you go out shopping? How did you get the setup started?
Yeah, so I reached out to some online like Facebook groups for lactation professionals to get other like lists of things like clinic supply lists. And so I got those from a few different sources and just kind of comb through and really be thinking about like what am I gonna need here? What are my priorities? And then, and not knowing quite, how often am I going to need an SNS, or, a Symphony breast pump, you got to make decisions about costs and things. And so, Yeah, so that's kind of how I started, with just getting ideas from what other people carry in their clinic setting, and then just made decisions. So, started out with the basics and then added things, like a doll and a nice breast, silicone breast that I use all the time, and I'm very glad to have those here. But, I'd be happy to share some of the things I use most, but yeah, I don't know how specific you want me to be. It was
And
fun to set everything up. Yeah.
sorry, I just wanted to make sure I addressed Lindsay's question in the chat. She missed where you're located. Could you describe again a name and describe your
Yeah.
clinic? Yeah.
Yeah. So I'm in Portland, Oregon, and I'm in a midwifery and OB clinic that is part of a hospital. So it's across the street from a hospital. Um, and we've got 9 midwives here and 4 OBs, and I work in 2 different locations. So I have a clinic that's right next to the hospital, and I have one that's about 5 miles away. And I'm in each space 2 days a week. Mhm.
Okay, I'll ask the question. What challenges, you already mentioned what's really cool about being right there with the midwives, but are there any challenges that you found?
Yeah, I think like the biggest challenge probably is the people having to come to me for their care. I mean, I often will tell people, I wish we could all come to you. You should be just at home in bed with baby for the first couple of weeks. And that might be on the horizon. We would love to be able to do home visits. Yeah, me and the midwives. But for now, and so it's like people have to decide, and sometimes they, don't want to leave when they're 5 days postpartum, and that's completely understandable. And just not having, the comfort of being in a home environment, or even just a little more, comfortable environment. I do, the best I can here, but it still has to be, everything wipeable. And so I think that you miss out on not being able to see a person's home environment in the clinic setting. But at the same time, it's really nice, having people come to you. You're able to see a lot more people in a day also.
And it sounds like that's such a great support to families where they're actually receiving, though it's not fully comprehensive, at least more comprehensive care by being able to see both their midwife and their lactation consultant at the same visit.
Yeah, yes, yeah. So most of the time, the midwife always comes in here. The way we do it, the midwife always comes in to a visit when it's their first visit. So they'll pop in and actually provide care for the baby, and establish care with the baby. But they are there and can see, the mom, if mom have questions. And then they're seeing the patient separately, for their postpartum care at their 1 week. But then there's like a day like today where somebody's coming in for their visit with a midwife, and they were having a lot of latch pain. And so I was able to just like add them, to a visit with me right after their appointment with the midwife. So they'll see her and then me. And yeah. So yeah, it is really convenient for them, and just being familiar, with the location and the clinic.
And also being able to see that you're collaborating with their other care provider too. Yeah.
Yeah, yeah,
It's huge.
yeah,
Yeah.
yeah.
Yeah, it looks like Julie has another question for you.
Thanks again. I think this came up when you were talking about the being able to do home visits and like that aspect of support and ease for new parents, etc. Do you do any kind of like texting support, or like do you keep like for like a phone follow-up that you do, like a little anything like that?
Yeah, I do. I don't do texting. I'm not sure if we have a secure way to do that, but I do my chart messages with patients. And so there's a couple kind of like touch points I have. So I will call people who delivered, the week prior. So you can look through all of our delivery reports from the hospital and call people who delivered, especially I kind of comb through and look for first time parents, or if they happen to not see the inpatient lactation consultant, I'll call them and just check in, around that day, like 5 or so, and say, see how they're doing, and if they, have questions or need an appointment. So that's that. And then for my patients, I will often, if they are deciding about a follow-up, if they want to do a follow-up or not, if they're kind of feeling like they might want to hold off and see how things go before scheduling a follow-up, I'll often say like, I'm gonna call you next week, to check in. So we'll do that a lot, and that's just a great kind of in between, if they don't necessarily need to come back for an appointment, but we just want to touch base and see how, make sure it's going well still too. So I send myself, a little in basket note to call a particular patient on a certain day. Yep. Yeah.
Awesome.
That works out really well. And it's nice right now because I don't have a completely full schedule already. I have time to do that, which I just think adds a, next level of care for our patients. And I really like being able to do that. It would be more challenging if I was booked full all the time. So.
Okay, thanks. That's really helpful.
Yeah.
All right, looks like Charissa has another question.
Do you work with or do any warm handoffs with the inpatient IBCLC, like, getting like the rundown on a patient before you see them? Because I'm sure there's like the concept of the wraparound care, because in my experience, we both did like in the practicum, we both did inpatient and outpatient in the settings I was in. And so a lot of times I would see people that I saw inpatient as outpatient. And if you're not seeing them inpatient, or like, if I was inpatient, I would be like, I wonder how that ended up working out. Or I hope they ended up seeing Nina because they needed it.
Yeah, that's a great question. Because we are a pretty small hospital, I had the inpatient lactation consultant and I are able to work really closely. And so we are using Teams, every day, pretty much communicating about a patient or something that's going on. So she can refer directly to me. So even before somebody discharges, she can set them up with an appointment with me. And then we also, each week, we communicate on like making calls to patients, or, hey, this person could use a call. They were, they didn't want to schedule an appointment when they discharged, but they were having a lot of nipple pain. And so, are you going to call them or should I call them? So we were often touching base on particular patients. And we occasionally will cover for each other also. So can, just keep in communication about particular patients that way too. I'm trying to think of another example. She has she's been here a little longer than I have too. And so it's nice to be able to reach out to her and ask, for her opinion on certain things, especially if she has seen that person inpatient already. It's just nice to have that context. So, yeah.
I also wanted to ask if you have seen, only because I know where you're at and I know other hospitals in the area have this problem too, not having an IBCLC on staff on the weekends. Or do you see that have repercussions like on your Monday morning? Like, are you getting a bunch of calls and messages from the parents that didn't, or families that didn't get any care over the weekend, lactation wise?
Yeah, no, people don't call as often as I'd want them to.
Right.
But that's why I call them. So on Monday or Tuesday, both Kawali, either of us will go through those reports. And, I prioritize people, who didn't see lactation. And for us, it's only a kind of a sliver. It's like, if they deliver on Friday night or Saturday, then they probably won't see lactation unless it was a C-section, and they'll still be here on Monday and they'll get seen. So there's just kind of that 24 hours, that they might not see anybody, because people discharge close to 24 hours here. So yeah, so I give them a call, especially if it's like the first time mom, and yeah, and the nurses they're pretty good about letting them know at least that there's outpatient lactation support if they need it, and give them my card. So occasionally we'll get a call, but usually it's when I reach out to them. It's hard to pick up the phone, and even if you're struggling, yeah.
Yeah, and so that is a nice segue into Gina's question about, are you the only outpatient IBCLC for this particular hospital? And then do you have an idea of what your monthly birth rate is?
Yeah, it's pretty small. I think I am the only one, and I want to say it's I'm gonna feel bad if I get this wrong. I think it's about 60 births a month. Maybe it's a little bit more now. That was last year before I was hired on. I remember the director saying about 60. So with the new, we have been growing. So maybe it's more than that. Sharissa, I don't know. Do you know, Sharissa? You might know.
No,
Here,
I think
the doula?
that sounds about right. I feel like Sydney might even know too. But I feel like
it's
we
more
only
than
have a
2
couple
a
babies
day.
a day. Yeah.
Yeah, I feel like it's a little bit more than 2. Well, but if you're averaging 2, yeah, it's pretty small. So I'm the only one outpatient, and I'm not full. So that kind of gives you an idea.
Like Dixie has a question.
Yes. So Nina, you were talking about the midwives doing virtual visits. Do you do virtual visits as well?
I do. Yeah.
Cool. And are you billing? Are those that you're billing for?
Yes, I can bill for the virtual visits as well. They just have to be in the state of Oregon.
Great. And then my other question is, what PR did they do to let people know about your services when you started offering services?
Yeah, so the marketing team has been really involved. I think they did like a promo video. I don't know if it's up on the website, but they have been reaching out, and then they're going to feature the women's clinic soon, and so we have a photo shoot coming up in June with like some model patients and stuff, and they're gonna highlight lactation also, so that's kind of exciting. And then one time marketing, I don't know, there was going to be something in a magazine. I'm not sure what it was, but they asked me, all these questions, and I gave them my answers. And I just the other day I was thinking, I don't ever really see where that was published. I should take a look at that and get a copy. So yeah, they've kind of consistently been reaching out for things specifically from me to kind of let folks know. And we only just started being able to see outside patients. It's especially babies that are a little bit older, it's a little bit tricky in this setting with the whole billing and everything. So we just recently more reached out to some of the pediatricians that are nearby at OHSU and at East Portland Peds to let them know we can see their patients, even if they're not, our clinic patients. And so, yeah, so we'll probably start doing more of that too.
Do you, my last question is, do you all have a support group that is offered for families after discharge?
That's a great question. Kawali and I are working on getting that started right now. We've got our plan, and we're just waiting for a space.
Great.
OHSU just remodeled a big portion of this building that I'm in, and I walked past a door that says education room, and it's brand new, and it's got carpet, and so I've got my eye on that space, so we just need to get a time slot.
Great.
All right, well, as these conversations tend to go, we wish we could talk. We have all the time in the world to talk, but I just wanted, Nina, first of all, I wanted to thank you for dropping in and sharing your experience with us. I'd also like to, for the sake of everybody's time and honoring people's time. I want to introduce two more folks that have dropped in to join us to share a little bit about their experience. And I'll start with Mary. Javiera, we'll get to you in just a minute. But I'll start with Mary. And Mary, if you can kind of tell us who you are, where you are, and how you got to the clinic you're in.
Hi, yeah. I work at Hillsborough Pediatric Clinic, and I've been here for 5 years, and there was already a lactation program for like almost 20 years before I joined. So Dr. Dahlquist kind of started it up, and it's been going well. Yeah.
Good.
Do you want me to go more into depth about like how we do it here?
I'd also like to have Javiera give her introduction as well, and then we'll start to ask questions of the both of you. How does that sound?
Yeah.
Hi, everyone. It's a little weird because I'm in my car, so I'm trying to find a spot that's a little bit less sunny, but you called on me, so I'm just gonna answer. I'm Javiera, and I work at UW, University of Washington in Seattle, and I work in their pediatric care center. And I've been there for a little bit over a year. Yeah, and I've been doing IBC. I've been doing lactation consultant work for a little bit over 2 years. So I came from another clinic.
Yes. So what we'd probably like both of you to talk about is since Nina gave us a perspective of working actually in a midwifery clinic, both of you are working in pediatric clinics, so it probably has a little different feel to it. So maybe Mary, we could start with you. Maybe you can talk a little bit about how lactation care is incorporated into your pediatric practice and how you manage that.
So we have like our little best beginnings group. So there's we have two doctors, one that's a lactation consultant, also one that's studying to become an IBCLC. And then we have two nurse practitioners that are also IBCLCs. So all the babies, no matter how they're fed, come through our little program first, where they get infant feeding support, however they're feeding their baby. And then either the doctor or nurse practitioner comes in afterwards to do the physical exam. And so we see them for the first 2 weeks for all babies, no matter how they're doing. And then continued support as needed for the breastfeeding babies or babies that aren't growing well. And like I'll do a lot of the questionnaires, like the developmental questions, and I do the metabolic screens, all that kind of thing. So it's just incorporated in with their well child checks. And then at the 1 month, they go into their own pediatrician within the clinic that they see after that.
Great. And Javiera, how about you? Maybe you could share a little bit about how lactation care is incorporated into your pediatric practice.
Okay, I think I found a better spot. I was listening, but I was also driving. So the way that we do it in our clinic is that even though I work in the pediatric clinic, I can see people from anywhere as long as they have some sort of connection to UW. And so that means that if they've had their baby at UW, or if they got their prenatal care at UW, or they're bringing their baby to our clinic, I can see them. So it's not really like paired up with their appointments or anything. It's very much like whoever needs it gets referred to us. And we are very full. And so sometimes people will ask us, will you open it to other people? And we just don't have the capacity to do that. But we get a huge range of, people, ages, where they come from, where they're getting their care. Yeah, it's really wonderful. Having the pediatricians working with me is really great because we've built a really good relationship. They trust us a lot. They really know that we're going to be very detailed in our feeding plans, and they will send lots of people to us. And I will speak for myself, but I'm very comfortable talking about anything feeding related beyond breastfeeding. And so my background, I'm a nurse, and my background is home visiting nursing and clinic nursing with moms and babies. So that has been super helpful to have. I don't think it's necessary, but I do think it helps a lot in the setting that I'm in.
Yeah, great. Good. Before I start peppering too many of my own questions, I'm just wondering if anybody here in the group has specific questions for Mary or Javiera at this point.
So I was wondering, Javier, if you mean like, oh, should we start solids soon? Should we be scheduling sleep in the night? Everyone's favorite question. Is that the kind of thing that folks will, your experience comes into play?
People, I think, ask about absolutely everything. So what is this rash? And what is this, is this normal newborn behavior? And why is my newborn waking up at night? And I think I try to answer a lot of those questions because I feel pretty confident in that, but I always try to tie it into what it means for their feeding, what it means for breastfeeding if they want to continue to breastfeed, what it means for bottle feeding. So for example, if somebody has sleep questions and they bring a newborn and they say, hey, I really want my baby to sleep through the night, but I also really want to breastfeed, then we can talk about what is a reasonable expectation for a newborn as far as sleep goes, but also knowing that things like, 12 hours by 12 weeks, the book, and giving baby lots of volume in bottles at night, how does that affect the breastfeeding relationship? And we talk about not necessarily like you need to do this to breastfeed, but really what are your goals? And for some families, mental health is actually for all families, mental health is a huge thing. And so if they say, I really want to breastfeed, but it's more important for me to sleep, and then we talk about how the sleep situations, things like sleep training later on can affect feeding. So we try to tie it in the same way the introduction of solids. So when you introduce solids, also knowing sometimes people will come in, they just introduce solids and now baby's not gaining weight. And maybe they didn't understand that they needed to continue to breastfeed around the clock. They needed to continue to formula feed if that's what they were doing. There's sometimes a little bit of, people get really excited about it and they might forget about that. So we tie it into all of that. And then the last thing that I will say is a lot of things that are like, I'm a huge like oral, like feeding, ties, aversions nerd. And so I sometimes will see babies who will have challenges in the beginning that if they are not addressed early on, continue to pop up. So I'll see them at different points in their journey, maybe, at 3 or 4 months having lots of reflux issues, and then introduction of solids, and then having like, they're picky eaters or they have aversions to certain things. And so I also do lots of referrals to oral and feeding therapy and all that stuff. So all of those things I find tie in together really nicely.
Yeah. And so this is actually a question for both of you. Maybe you could, Mary, maybe you could start kind of describing how when there are more complex challenges, how you collaborate with the pediatrician and how you're able to kind of do that since you're both on site together.
Yeah, it's super great because we definitely bounce things off of each other. And we work really closely together. So they always get to see a provider with each appointment. And, sometimes it's just like, if it's a provider that isn't in our, best beginnings team, sometimes we'll kind of go back and forth with them coming in for weight checks with me or lactation support, and then they can see the chart notes, or I'll send them a message if it's something more urgent.
And Javier, how about you?
For me, I think I work in a very unique place because a lot of our doctors are residents, and their skills and their abilities and their confidence are very diverse because we get people who are very like fresh, residents in their year 1, and then residents in year 3, which is such a huge difference. And I find that the residents tend to really lean on us a lot, and they'll come to us and they'll say, "Hey, what would you do? What do you think about this feeding thing? And can you make a plan for this family?" So they come to us a lot as sort of like more of the experts. And I find that even in our clinic, even the attending doctors are very much like, you are in such good hands with lactation, because we know that if you go there, you're going to come back and your baby's going to be gaining an ounce a day and you're going to have a plan. So I find that they defer to us a lot, but we work very collaborative. Like our collaboration goes both ways, of course, because they're the ones taking care of other things. So when people come to the visit, I get a full hour, which not everybody gets that, but I get a full hour with a dyad, and that is packed with information. So if they are having issues, like, hey, I have this rash or I have this, then I can send them to the pediatrician, kind of say like, what is your scope? What is my scope? How do we work together? And then also with their referrals, I do lots of, I send my charts out all the time. I note, I CC the doctors and I say, hey, what do you think about making a referral to Seattle Children's Feeding Therapy? Or I refer a lot to people who do frenectomies and frenotomies that I really trust in the area. And so we work as a team a lot, and it's very back and forth. It's very like, hey, this is working, this is not. Because we're booked so far in advance, sometimes I'll say, hey, I can't do your weight check next week, but you can do it with your doctor. She has openings. And then I'll send that to the doctor. And then I'll say, hey, doctor, this is what we're working on. Can you follow up on this and that? And they'll say, yeah, absolutely. So if they come back in a week and weight gain is not looking good, they can make adjustments. And then I see them the following week. So constantly working together. Much easier when people are seen in our clinic. Because other clinics, as long as they're using the same system, it's much easier, but some clinics are not. And so then I have to fax notes, I have to make phone calls, and every pediatrician practices so differently. I mean, even like when it comes to daily weight gain averages, some doctors are like, I want to see any weight gain, like 5 grams a day, great, like that is weight gain. And some doctors are like, no, absolutely not. If I don't see 30 grams a day, I'm concerned. And so it's been kind of fun to work with people who are very different, have very different approaches.
Great. Yes, I'll just take a pause on my questions if anybody else has any other questions for Mary or Javiera, or even for Nina. Yes, looks like Dixie has a question.
So, Mary, so Javiera talked about her background, that she's a nurse. So Mary, could you share, did I miss that? Did you already share your background with people?
Yeah, no, I have a bachelor's in human development and family sciences. I'm not a nurse. And I have lots of lactation training, all the prerequisites, of course, for the medical side. But that's a great thing about working in the pediatric clinic so close with doctors, right? They're signing off on everything and making sure everything looks good. So it's nice to be able to have a job where I didn't have to go through nursing school.
And do you want to tell people where you worked before?
Yeah, before I used to work at WIC, and yeah, they were very supportive in helping me get all the education and training I needed to become an IBCLC.
Very good.
Thanks.
Great. All right. So now this is this was a question that was posed to Nina, so maybe Mary and Javiera could address this one too. So it sounds like you're doing a lot of great things supporting families and helping families move forward. Where do you find some of your biggest challenges and some of your biggest obstacles? Sounds like for Javiera, your schedule. Sounds like you guys are always booked out. But maybe you could talk about some of the other things that you find, because of your unique environments. What might be some unique challenges to where you are?
I think that some of the unique challenges that I face working in a pediatric clinic is that I don't see babies, right? I see dyads. And so sometimes people come because the baby's having an issue. So maybe it's, something going on with the suck or something going on with the weight gain. And usually I can work with the pediatricians on that. But if it's something going on with mom, It is very, very, very challenging because I don't have that same relationship. Like here in this community, I get pretty like I get a lot of frequent referrals from the same providers, and clearly they like the work that we're doing. I like the work that we work really well together, even though they're in different clinics. Even if I've never met them, I just see the same names and then I send them messages and they reply. But I don't have that same relationship in Seattle with the OBs, and there's so many, and they have such different approaches, and so things like like my mom experiencing nipple pain or things like mastitis and people having different approaches to that and me being like, okay, I really recommend this. And I would love for you to get to contact your provider. So for example, a provider might, be comfortable prescribing something like Apno, like all-purpose nipple ointment. And that's what they will do. And so I kind of have to follow what they're doing. And some provider might say, a patient might say, hey, can I use Apno? What do you know about that? So I tell them, what it is and what I think of it. And then they'll say, okay, I'm going to go to my OB and get it. And then the OB says, absolutely not. And so then I'm like, what do you prescribe? And they'll say, I don't know. What should I prescribe? And I'm like, okay, maybe a mild steroid or, and so having to kind of do that and kind of having to chase people around for the mom to get care is very challenging from my end. The biggest one I would say is things like low milk production.
Oops, we might have just lost Javier for a second there.
Oh,
yeah.
Oh, you do have me? Am I back? Am I back?
Oh, yes, now you're back. Yeah.
I'm back. Okay. I would say, something like milk production, low milk production, where I would love, because the clinic where I worked before, I was able to do things like we were able to do blood draws and check prolactin levels, check thyroids. I was working alongside IBCLCs who were providers who were able to order those things for me. We were able to collect that, get data. They were able to prescribe, if they wanted to do Reglan or something like that. I was so used to that. And so I was used to having that partnership with somebody who was able to order things, order labs, diagnose things, treat things. And now I don't have any of it. And so when I have people and we've tried other things, we've tried to boost prolactin naturally and we try to do other things, or, I can't diagnose tongue tie. I can't diagnose, insufficient glandular tissue. I can't do those things, but I can send them to a place that they can diagnose those things. But I always hate to do that because when you have a brand new baby, you don't really want to be going around and making appointments. And so, yeah, that's the biggest challenge. I mean, even talking about it, I'm like, man, this is a myth. But it really is. I mean, we're always trying to chase people around and try to get referrals and try to get medications prescribed. But yeah, that's hard.
Yeah. Yes, that sounds very difficult. Mary, what about you? Do you find similar challenges in, since you are seeing a dyad, but maybe unable to give maternal care?
It depends on who's with me. The pediatric nurse practitioners cannot do mother care if they're over, I think, 18 years old. But if I'm with one of the doctors, we can do both mom and baby. So we can treat mom for mastitis. We have therapeutic ultrasound. Two of the doctors do frenotomies. So it's really nice just having lots of care within one spot and being able to give them care right away.
That's great. That sounds fantastic. Yeah, good. Good. All right. So I want to be mindful of time. We have about 2 minutes left. Just want to see if any of our participants today have any other questions for our three panelists. You're all ready now to go set up your lactation practice in a pediatric office.
Oh, I'm gonna ask Mary and Javier. It sounds like you all came into spots that were already going, but did you get or have to do any setup on your own, like charting or equipment or anything?
No, just learning how the clinic does it, but everything was well set up by the time I got here.
Got it.
Good, good.
Our program was set up by somebody who's in leadership. So she was our nurse manager. So she had very little time to devote to it. She loved it. She was very passionate about it, but she couldn't really grow it. and they had one other nurse who still works with me, but she was only there once a week. So when I came, I changed a lot of stuff, and they gave me that freedom and that support to do that. And so now I've changed the charting, I've changed a lot of stuff, and I get a lot of students. So tons of medical students. I love people shadowing me, and I've been able to establish that on my own because I really love that. But I work with super supportive people. So I'm very lonely there because it's just me doing lactation. There's no other support. I don't really have a team. So I work with other nurses, but they don't do anything that I do. So it's just, a lot of support from leadership is important in my case because they are okay with my crazy ideas for the most part, and they let me run with it.
That sounds great. That sounds great. Yeah, good.
Yeah.
All right. So if our panelists are okay with providing their contact info in the chat, so if others, down the road have questions that come up and would like to contact you, if you guys could put your contact info in the chat, that would be really great. And we want to thank you all for joining us today for our drop-in lunch and learn. If you subscribe to our newsletter, or you go onto our website, you can see upcoming events as they get planned, and we'd love to have you join us for another one. So if you guys have any questions or any concerns about anything, or if you're looking for contacts, looking to network, know that we're always available, so never hesitate to reach out and let us know. Thanks, everybody.